Skeletal System of Pediatrics. So we'll start with developmental dysplasia of the hip. So with developmental dysplasia of the hip, the head of the child's femur will be seated improperly in the joint or the hip socket. So in a neonate, you are going to see laxity of the ligaments around the hip. In an infant, you're going to see shortening of the limb on the affected side, which is known as Galeazzi sign or Alice sign, is when you have a shortening of the limb on the affected side. You're going to see unequal gluteal folds, limited range of motion in the affected hip, and then you're going to have a positive Ortolani's test and a positive Barlow's test. So an Ortolani's test is when the examiner abducts the thigh and then applies gentle pressure forward and over the greater trochanter. A positive Ortolani's test is a clicking sensation, which indicates that the femoral head is dislocated. Whereas a Barlow's test, the examiner is going to adduct the hips and apply gentle pressure down and back with the thumbs. A positive Barlow's test is when the examiner can feel the femoral head move out of the hip socket. In an older child, the affected leg is going to be shorter. They're going to have a positive Trendelenburg sign, and then their greater trochanter is going to be prominent. So with the Trendelenburg sign, so the child is instructed to stand on one foot and then stand on the other foot, holding on to support and bearing weight on the affected hip. A positive Trendelenburg sign is when the pelvis tilts downward on the affected side instead of upward. So there are also with bilateral dislocations, there's going to be a marked lordosis and a waddling gait noted, but certainly know the signs of developmental dysplasia of the hip in a neonate, an infant, and an older child. So there's different degrees of dysplasia. So we have preluxation, which is the mildest form where the femoral head stays in that socket. Then you have subluxation, which is where there's incomplete dislocation of the hip. The femoral head remains in the hip socket, but there's a stretched capsule and ligamentation. It causes the head of the femur to be partially displaced. And then dislocation is when the femoral head loses complete contact with the hip socket. So interventions for hip dysplasia. In birth to 6 months of age, the hips will be splinted with what is known as a Pavlik harness. So this harness will be worn continuously until the hips are stable in 3 to 6 months. Interventions for a 6-month-old to 18-month-old. This child will be placed in what is called a hip spica cast. They will wear it for 2 to 4 months until the hip is stable. And if it's diagnosed in an older child, an operation is usually required. So congenital clubfoot. So you have 4 different types. You have varus, which is inversion or bending inward, valgus, which is eversion or bending outward. You have equinus, which is where there's plantar flexion, and then calcaneus, which is where there's dorsiflexion. Definitely know the difference between those. Treatment for congenital clubfoot is going to begin soon after birth. There will be manipulation and casting that's usually done weekly for 8 to 12 weeks. And then after that, a splint will be applied. Surgery may be needed if normal alignment is not achieved by 6 to 12 weeks of age. Also, you want to contact the primary care provider immediately if there are any signs of neurovascular impairment noted in the child with the cast or brace. So idiopathic scoliosis, this is usually diagnosed during the pre-adolescent growth spurt. This is why screenings are so important when growth spurts do occur. It involves the lateral curvature and spinal rotation that results in rib asymmetry and hypokyphosis of the thorax. So on assessment, the examiner is going to ask the child to perform the Adams test. This will result in asymmetry of the ribs and flanks when the child bends forward at the waist and hangs the arm down towards the feet. There's going to be an asymmetry of the hip height, asymmetry in the rib positioning, and asymmetry in shoulder height as well. So it can be surgically corrected, but if they are still growing and maturing, it may be attempted to be corrected non-surgically with bracing. Bracing is non-curative, but it helps to slow the progression of the curvature to allow for skeletal growth and maturity. That brace is usually worn for anywhere from 16 to 23 hours per day. After the child has grown and matured, then surgical correction can be performed. And then post-op from surgery, you want to teach log rolling maneuvers to help to maintain the proper alignment of the spine. And then you're going to monitor for what's known as superior mesenteric artery syndrome, which the signs and symptoms include vomiting or abdominal distension. Okay, juvenile idiopathic arthritis. It's most common in girls. It's an autoimmune inflammatory disease that affects the joints and other tissues. Treatment is supportive, so there's no cure. An X-ray may show some soft tissue swelling and joint space widening from increased synovial fluid in the joint. Assessment findings are going to be similar to assessment findings of arthritis in adults. So these children may have stiffness, swelling, and limited motion in the joints. The affected joints may be warm to touch, tender, and painful. There may be joint stiffness that's present in the mornings and after prolonged inactivity. And then uveitis may even occur and cause blindness. Okay, Morphean syndrome. Morphean syndrome is a disorder of the connective tissue that affects the skeletal system, the cardiovascular system, the eyes, and the skin. So it's caused by defects in the fibrillin 1 gene. The fibrillin 1 gene serves as a building block for elastic tissue in the body. So it's caused by defects in the fibrillin 1 gene. There is no cure for Morphean syndrome, unfortunately. This patient is going to be very tall, have a thin body structure with very slender fingers. They're going to have a curvature of the spine, and then they're going to have the presence of visual and cardiac problems as well. Okay, leg calf Perth's disease. So this is a condition affecting the hip where in the location where the femur and the pelvis meet the hip. So the blood supply is temporarily interrupted to the head of the femur, and then the bone dies and stops growing. So this child is going to present with limping, limited range of motion, pain, and joint stiffness in the affected hip. So this may require a hip replacement surgery. You will want to educate the patient on the use of crutches to avoid weight bearing and the importance of bed rest as well. All right, so a child with fractures, of course, they're going to have pain. You may see an obvious deformity. They may have loss of function or crepitation on exam. Very important to remember that fractures in infancy are very rare, and they will always warrant further investigation to rule out the possibility of child abuse or to identify bone structure deficits.